So I am going to talk to you about renal sonography today. It's a broad topic, so I'm going to try to consolidate into, what's really important to know. I know renal artery Doppler was important to touch upon today, but I think in order to get to renal artery Doppler, it's important just to understand what a general renal ultrasound would look like. So we're going to talk about that. We're going to talk about renal structure, equipment, pathology, some disease processes, including some congenital variants that sometimes can fake us out, and then finish up with the spectral Doppler analysis. So why we want to talk about this is chronic kidney disease is worldwide, affecting about 10% of the population. Over 800 million people worldwide are impacted by chronic kidney disease. It affects us as we get older. Females are more prevalent, certain races, definitely history of diabetes and hypertension. Countries that have less resources have a bigger burden to carry with this. But we know sonography can help with screening, and we'll talk about the benefits of sonography in a little bit. We want to kind of get ahead of this if we can, because it is a leading cause, and it's increasing every year for mortality worldwide. So why you would be asked to do, or some reasons to perform a renal ultrasound include pain, especially back pain on either side of the spine. Urinalysis is abnormal or perceived or noted blood in the urine. Hypertension is a big one. Evaluation of known pathology, abnormal labs, and trauma to the area. So I think next to the spleen, the kidney is the most impacted by blunt force trauma. So this could be part of a POCUS scan as well. So I say to all prospective students and current students, why I love sonography is we're safe, we're portable, and we're affordable. That's my spiel. And I think that it's really helpful because this gives us an opportunity to assess patients quickly and get a sense for where they are from a renal structure standpoint, perfusion standpoint, and we can even get those Dopplers to see, are they starting to fall out of the abnormal range? So just a review on anatomy. So the kidney has kind of two sections. That middle medulla comprises most of the bulk of the kidney, but a lot of that is vasculature, lymphatics, fat, and drainage. I always say the cortex, while it's very thin compared to the medulla, that outer cortex is where all the good stuff is. So without that thin cortical layer that holds the nephron that carries out the function, our kidney wouldn't be able to carry out its tasks. So that cortical thickness is really important when you're looking at the kidney. We'll talk about how you can measure that to determine if maybe that's getting a little too thin. So all the good stuff happens in that cortex. So a little bit about equipment and system functions. I know you've had some of you maybe were on the previous two presentations this week. So this might be a review from your current practice or from those presentations, but our transducer is kind of where you want to start when you're setting up your system to scan. So depending on the system, you will find where the transducer keys are, and you'll select the curvilinear transducer. So there's an image of it in the upper right-hand corner. The reason why the curvilinear is the preferred transducer is because it has a wider field of view, so you can get all of the kidney on your image. Once you select that curved transducer, you can then, what will propagate into your system are exams that fit that transducer. So if you start by selecting the transducer, then you go to your preset, and then you select that you want to do a renal ultrasound. So it kind of all starts with that transducer. And then you start looking around your system and you get quickly overwhelmed because there's so many options on that keyboard, right? So it can be overwhelming, but I am here to tell you that you only need to know a few to get the job done. So you can do a good screening assessment of the kidneys by just those few listed on the bottom right. So depending on your system, these might be called something different, which is frustrating. It's like when you change cars and you're trying to find where your windshield wipers are, and you know there's a button for it, but you don't know where it is on this different car. That's how ultrasound systems are. So if you are scanning in grayscale, the button that you would look for is either B for B mode. So you can see that on the knobology system on the right, and then, or it could be called 2D, which you'd see circled in the middle here on the system on the left, right here. Gain is important. It can turn up the brightness or turn down the brightness. So if your image appears too bright, you can use that as a quick kind of assessment just to turn down. You can look at depth. So depth is an important key. You can see it here on the system, and you can see it, I have to move my thumbnail here. You can see it over here on the system on the right. Depth is a great tool to get your image centered. So if your kidney is way up on top and you have all this information that you don't need after it, you can adjust your depth to center it. And conversely, if your kidney is kind of cut off at the bottom of your image, you can adjust your depth to center it. We'll talk about color and pulse wave Doppler a little bit later, but those are buttons you would want to be familiar with. Even if you're not doing a Doppler study, it is helpful to put color on a kidney just to look for perfusion. Okay, so this is what our American College of Radiology, ACR for short, tells labs that are accredited through them that they need to do for a renal ultrasound. So it's important to take images in two planes, assess length, look at echo texture. We're going to talk about all of that. The purpose that for why I share this slide with you is because protocols, I think in general, are important for a few reasons. One, they help with consistency. So if you're following someone else's work and they're doing the same protocol, it makes it easier. And ultimately outcomes for the patient are better. If everyone's measuring length and everyone's assessing echo texture and we're all doing that, we know if there's a change. We know that it's more likely that a change has occurred. It's also helpful because it keeps you on track. You can quickly get into the weeds with some of this stuff when you're kind of scanning around. So it kind of keeps you on task. And then in some cases, if you want to be accredited, your lab wants to be accredited or you want to bill, you will have to follow protocols. So there's kind of three important reasons I think that protocols are helpful. So we're going to perform a renal ultrasound. We've selected our probe. We've selected our presets. We've kind of got a good lay of the land where your knobs are. And just in general, these ultrasounds will typically be bilateral. It is possible that maybe you only need to look at one kidney, but if we're really looking for function and we think function is impacted, we want to look at both. All organs get looked at in two planes, so we'll talk about long and transverse. It's important to remember additional strategies. So respiration, having the patient take a deep breath in will help push that kidney down. The lungs expand, the diaphragm pushes the organs in the abdomen down, so we can work around the rib cage a little bit better. We are going to look at the echo texture of the kidney and understand what normal looks like. And then we're going to compare it to the adjacent structures. So on the right side, we're going to compare to the liver. And on the left side, we're going to compare to the spleen. It's important to measure the length of the kidney. That some places will say measure 3 dimensions, but the length is the one that you always want to make sure you get. Length is a determiner of how if function is decreasing, the kidney will get smaller. So the normal length of an adult kidney, and this might vary a little bit depending on its source, is 9 to 12 centimeters. So if you put your caliper, as in that picture, from the top of the kidney to the bottom, you should have something between 9 and 12 centimeters. If it's bigger than that, that might be indicative of some process, but we're kind of talking about chronic kidney disease. So we're really looking for a kidney that's shrinking down. Also, something to be mindful of is the difference between sizes between the two kidneys. So if a kidney on the right side is measuring 10, but on the left is only measuring 7, that kidney is too small and there's discrepancy. So it really does point us in the direction that we need to look more at that left kidney for an inclusive process. The cortex. So I mentioned earlier that all the good stuff that we need the kidney to do happens in that cortex. It's not very thick compared to the rest of the kidney. So you can see the parenchymal thickness is in this green dashed arrow, but the cortical thickness is in that yellow dashed arrow. That is a good cortical measurement. You're going to measure from the outer gyrotous fascia to the base of the pyramid, which is this hypoechoic structure here. If that measurement is less than 6 millimeters, it could be indicating that that function is starting to diminish. Here's some more structures that you want to be aware of. So if we look at the kidney, when we go kind of from outside the kidney to the inside of the kidney, I think of it as hyperechoic because we have the perinephric fat and gyrotous fascia. And then we come into the cortex and the pyramids, which will be more hypoechoic. And then as we get to the center of the kidney, we see that compact renal sinus that's filled with lymphatics and fat and blood vessels. Everything's kind of packed in there. So we get more a dense appearance to the center of the kidney. So it kind of goes hyperechoic, hypoechoic, hyperechoic. So we talked at a previous slide about that comparative texture of the kidney. We look at the image on the left, which tells us that there is normal comparative texture between the right kidney and the liver. And we should see that outer cortex of the kidney should be equal or slightly hypoechoic compared to the liver. In the middle image, we see the kidney looks more hyper or brighter than the liver tissue. That's probably not the one we see in the United States as much. That could be a process going on with the kidney. Maybe the kidney has got an inflammatory process going on. The one we see most frequently is the one on the right, where the kidney looks much darker or hypoechoic compared to the liver tissue. What's happening in the picture on the right is not a kidney problem, it's a liver problem. And so that is the appearance of a fatty liver or steatosis. So it's important to kind of be mindful of the comparative textures. We're going to start scanning, and this is a very basic diagram. But what we're worried about or our problems with scanning the kidneys is they're so far posterior in the body, we can't approach them posteriorly. So our options are approaching anteriorly or approaching from the side. So you can kind of see those little probe diagrams. We can try going anterior through the liver to get to the right kidney, but we're going to prefer something more to the side. On the left side of the body, we have to come from the side, and that's because that stomach is problematic for us. We don't like the air in the stomach, and it reduces our visibility. So we're going to look at the right kidney in longitudinal. We're going to go intercostal through that mid-axillary line. Oh, I apologize here. There we go. There is the mid-axillary line. So just from the armpit down, you're going to find that 10th to 11th rib space just below or just inferior to the liver. You're going to put the notch of your probe towards the patient's head. So we have the transducer will have a notch, and you'll put that up or superior on the patient. Like that. So you can see they're showing that red arrow is the notch. I wouldn't hold it like this, but we'll talk about that in a different lecture. That'll be ergonomics. And this is what we should get. So we have nice picture of the liver. We have the kidney. We can see that interface. Morrison's pouch is that potential space between the two. I would say we have a little too much depth here because they're showing the psoas muscle and the spine. We don't care about this stuff right now. We're focusing on the kidney. So you could reduce your depth, go more shallow to get that kidney centered better. I did have a little video here. It looks like it's not working now. We would, from a longitudinal probe position, we would turn 90 degrees to get the axial view of the kidney. The probe notch would actually turn posterior on the patient's body. That would give us correct orientation. And then we would slide our probe superior or angle or fan superior to inferior, documenting images throughout that kidney as we move transverse. Left kidney. So again, we cannot do an anterior approach. We have to come from the side. The kidney on the left side is going to be slightly higher in the body. So we're going to be around the 8th to 9th rib intercostal space. And that's because the spleen is smaller in size than the liver. So that left kidney sits up higher. The notch will still go up, and we're still along that axillary line. We will turn 90 degrees. And now for this rotation, your notch of your transducer is actually going to point anteriorly on the body. So you're going to turn that notch forward or anterior. And then again, you're going to sweep through the kidney superior to inferior. I'm doing one slide about the bladder. I didn't want to leave out the bladder because it is part of the function. So if we have a kidney that is obstructed or a kidney that's not functioning, that will impact what we see in the bladder. So it's all one system. So if you're doing a bilateral renal exam because you're worried about function, it would be prudent to go down to the bladder and just take a look. So a basic 2-plane, look at it in long, look at it in transverse. If it's a female patient, you might see the uterus posterior. If it's a male patient, you might see the prostate. If it's an older male, the prostate might be pressing into the bladder. So be mindful of those things. At minimum, I would do color Doppler with a posterior angle to look at ureteral jets. So that tells us that there is urine getting pushed through from the kidney to the bladder. So that color Doppler will show the motion of the urine as it's entering the bladder. If you're concerned about volume, you can always do a pre and a post volume assessment. If you're worried that maybe the problem is not being able to empty. So we can look for post-void residual by doing a pre and a post-void volume measuring in 3 planes. So moving on to pathology, this is not an exhaustive list of pathologies. So I'm just prioritizing on common ones and prioritizing on, things that, maybe stump us a little bit from time to time. So, of course, the kidney, a big culprit or problem for the kidney is obstruction. So something blocks the passage of the urine to get from point A to point B. So if we remember what the kidney should look like, when there's a backup or hydronephrosis, it becomes, I think, quickly apparent. So here is an example of hydronephrosis. We stage hydronephrosis as mild, moderate, severe, or sometimes it's graded, like grade 1 through 3 or 1 through 4. On the bottom left, you can see a little bit of mild hydronephrosis or pylectasis. The middle image definitely looks more prominent. And when we get into that severe or right-sided image, what starts to happen is the kidney kind of gets so filled or backed up with urine that the cortex will start to thin. So it's kind of getting stretched to its capacity. You know, how we manage and what we do next is kind of based on how significant is the obstructive process that's backing the system up. If it's really severe, you might also see hydroureter or sometimes called megaureter. Again, follow these obstructions. The obstruction, the end of the dilation will lead you to whatever is obstructing the system. So in the case on the image on the right, you see the arrow pointing to that ureter. That ureter is dilated all the way to the junction of the bladder, so that ureterovesical junction. So there is a problem probably right at that point that's causing, there's a stricture, a stone, something. So we always say, let the dilation lead you to the obstruction. The dilation will always be proximal to whatever's causing the problem. Usually what's causing the problem is this guy. So our friend, the kidney stone or nephrolithiasis, we see these, and when they're big enough, I always say they kind of quack like a duck. They are very obvious. So we'll see a highly attenuating hyperechoic structure that's so dense that when the sound beam hits it, it doesn't know what to do after. And so it just places a shadow. So a highly attenuating echogenic structure with a posterior shadow in the kidney is the findings for renal calculus. We can also put color Doppler on a renal stone and get something called the twinkle artifact. So you can see that in the bottom right of the image. Twinkle artifact happens so that the color Doppler will twinkle down. And you want to have specific settings for this. So we want a very high scale or high PRF, pulse repetition frequency, in order to elicit this response. It is more sensitive when the stones are really small. So if we are looking at that renal sinus that's already very dense and we're trying to figure out, could there be a little tiny stone in there? You would use this color Doppler technique to determine that. And I'm going to show you an example. So here is a kidney on the left, and you can see the calipers there. They're already kind of pointing out that calculus that's very tiny. We don't see a prominent shadow. One thing you could do is you could increase your frequency of scan, your transducer frequency. Sometimes that helps produce the shadow, but a quick color switch and you can see that twinkle clearly. So it is a helpful tool if someone's dealing with hematuria, pain, and they might have these little stones that are forming. Renal cysts, just quickly, a cyst is a cyst in the body. So the 3 criteria for a cyst is that it's anechoic. So the sound beam passes right on through it. That's called through transmission. And afterwards creates this artifact of sound called enhancement. So in the image on the left in A, you can see a nice anechoic structure. And then you see that posterior enhancement that's illustrated with the dotted line. Sometimes the cysts are collections of cysts, and usually when we see many cysts, there's probably a hereditary or bigger picture going on. Just as an aside, 50% of people over 50 will have renal cysts of some variety. But if you see many, it's probably more of a genetic cause. And when we worry that the cysts are completely anechoic, you might want to point out the features, and then they will maybe potentially put them in a Bosniak classification. This is more of a CT thing, but ultrasound's adopting it as well. So what do we do when something doesn't look straightforward? They might want to watch it. So that's just something you can research if you see a cyst that's not straight, purely simple. And then as we move to chronic kidney disease, we'll talk about the impact with perfusion. But here are two examples of very tiny kidneys, so tiny, the one on the left, you'll have to take their word for it that that's even a kidney. So it's so small. So the definition of chronic kidney disease, CKD for short, is parenchymal disease causing fibrosis and decreased function. So as the organ stops functioning, it just starts to shut down and becomes necrotic, fibrotic. Most of the time, chronic kidney disease will be a lab diagnosis with the pairing of ultrasound. So we really are looking at glomerular filtration rate, or GFR, to kind of stage where someone's at with chronic kidney disease. Neoplasm of the kidneys. So this is important too. You might be asked to take a look at the kidney and you see a structural change, so a new growth. Sadly, if you see a growth that isn't a simple cyst, and it has like some solid components, 85% of those are going to be cancer. So we assume it's cancer until proven otherwise. So renal cell carcinoma, or RCC, is the most common neoplasm of the kidney, unfortunately. So it's hard to differentiate until we get biopsy. So we wouldn't want to follow it. We would want to make sure we find out from a pathology standpoint what those cells are. Here are some examples, sonographic examples of RCC. So it's usually doesn't look that scary when you compare to like breast cancer and other cancers in the body. They're very uniform looking and solid and well-defined. A lot of times when we think cancer, we think, jagged margins and, multiple echo textures. These look a little more smooth. So the picture on the left is a smaller RCC. And then the picture on the right is much larger RCC. If you put color Doppler on RCC, you have this interesting kind of what we wouldn't anticipate a cancerous mass to have. We would anticipate a cancer to have very hyperemic flow. RCCs have what's called a basket sign. So it almost is more of a peripheral predominant flow. So that is an example of that. Again, we're going to assume all masses are cancer until we prove otherwise. Here are some benign ones. So an angiomyolipoma is more hyperechoic, more common, but overall not as a much lower incidence compared to RCC. And then on the right is an oncocytoma, which is like a mixed tumor that will typically have a spoke wheel vascular pattern. So you can differentiate that one from an RCC because of the vascular pattern it will present with. So some congenital variants that I think can trick us. They can be mass mimicker. So this is not an exhaustive list. So there's way more variants out there than what I'm going to talk about today. But these are the ones that I think can fake us out. So you can see on the left, we have a hypertrophic or a very wide column of Burton, and it's shown with the yellow arrows, the little carrots there. That could mimic a mass. If we go back to that renal cell carcinoma picture I just showed you, it has kind of the similar sonographic texture, but this is a normal variant. The differential between a column of Burton is the duplex collecting system. So if you go over to the image on the right, you see we also have some cortical extension on this kidney. The difference between the one on the left and the one on the right is the column of tissue that's wider or hypertrophic will not go all the way through the renal sinus. This one will. So this one tells us there's two collecting systems. This one's more vulnerable for hydronephrosis because the ureters can get kinked. Also, one that can fake us out is the dromedary hump. So you can see on this kidney that hump here, usually these are left side They a lot of times can be due to molding artifacts, but this could make us concerned that this could be a mass sitting here. Junctional defect is less of a fake out. We have crazy things that can happen in embryologic development. So kidneys can cross over the body and both wind up on one side. So they can cross over and they can fuse together. So the most common abnormal location and fusion is actually the horseshoe kidney. So you can see that in this image on the sonographic image on the right, and it's also in this diagram next to it. So the kidney is fused at the lower poles and it sits centrally across the great vessels. So I share this with you because if you go and look for the kidneys and where they are normally supposed to be, and you're not finding them, you might want to try just scanning over midline. You might see a suggestion of the kidney, but it looks anomalously placed in the body. Make sure you're looking at those inferior poles, that if you're following the kidney, it might lead you right over the center, over the great vessels. So you can see the kidney tissue is draping over the aorta in that image. The image on the left is a pelvic kidney. So that's the most common ectopic location where the kidney just did not get the memo and did not make its way up to the sides of the spine. It stayed down in the pelvis. Okay, so that's a general overview of renal ultrasound. So I would like to talk now a little bit about adding the duplex to this. So why you would add duplex, so this would be color and spectral Doppler. The big one is hypertension. So we have either hypertension that's not responsive to medicine, hypertension that's longstanding. It could be that you might want to evaluate a renal transplant, or maybe you are suspicious that these vessels are stenotic or thrombosed. So a review of how circulation to the kidney works. So it all starts with the aorta. The aorta will give rise to the right and left renal artery. At the hilum of the kidney, you'll have your segmentals. They're usually about 4 to 5. And then as the vessels move out to the cortex, it's kind of like tree branches. So then we have more interlobar between the pyramids. We'll have arcuate arteries that course horizontally over the base of the pyramids. And then little tiny intralobular arteries that are that feed that cortex. So as we go out further, the vessels get smaller. And how we interrogate these vessels is very lab dependent. So I'm going to give you an overview, but your lab and what you decide to do might vary a little bit, and that's okay. So when we assess the renal perfusion, we're looking at it from 2 approaches. So there is a direct method and an indirect method. And so the direct method is the aorta and the renal artery. The indirect method is going to be the intrarenal vessels. So those little vessels in the kidney, you're going to assess those. All labs or protocols will incorporate a combination of both the direct and the indirect. What can vary is that what we interrogate for the indirect method. So for instance, segmental arteries are an ACR, American College of Radiology requirement. So those are the ones most labs in my area will assess. So limitations with Doppler is a lot of, I mean, we're talking about tiny vessels in an area that we have to negotiate between ribs around bowel. They're deep in the body. So is the patient able to hold their breath? So you can get a Doppler waveform. Maybe we have bowel gas, body habitus. There's a lot of duplication to these vessels. So the image that you see on the right is a beautiful image from the internet where you can see the duplicated renal arteries. So unfortunately, You have to interrogate both of those. So that kind of doubles the length of your interrogation time. Scar tissue or underlying vascular disease can also limit us because it makes these structures harder to attenuate. So in the direct technique, we're looking at the aorta and the renal artery on both sides. So we're going to do a proximal aorta, just proximal to the renal artery, the level of the renal arteries. And then we're going to grab Dopplers of the renal artery along its path. We are going to always assess the kidneys in grayscale or B mode, just like we did for a renal exam. So we don't want to just get to the Doppler. We want to make sure we're looking at texture. So don't forget that that's important. And don't forget that the length of the kidney can determine how well it's performing. And if you have a discrepancy in size greater than 2 centimeters between the right and the left, that might tell you which one to spend more time on. So the smaller kidney is the one that might be having the issue. So you are going to get an aorta waveform, just proximal to the level of the renals. And so the image on the left is a normal aorta waveform, that triphasic flow. You're going to record peak systole. So you would take a caliper and you would measure how fast that blood is moving. That's the only measurement we care about. I mean, you can certainly get diastole, but we're going to compare peak systole to the aorta, and then compare that to the renal artery. So in an anterior approach, directly over the patient's anterior, you're going to get that aorta Doppler, and you're going to get the origin of the renal artery. So that is what's illustrated here on the right. It's hard to get these two from any other approach other than anterior. Important to remember, your Doppler angle should always be less than 60 degrees. So we'll talk about that in upcoming slides. So you want to make sure this Doppler angle of insonation is 60 degrees or less. The renal artery should be low resistance. So this kidney, if it's doing its job well, is filtering the blood constantly. So it is a vital organ. So we're going to see continuous flow throughout the cardiac cycle. That's low resistive waveform. So forward flow in systole, forward flow in diastole, as much as we can get through is great. And even spectral broadening is appropriate to see. So everybody's moving forward at all times. All these red blood cells just keep moving forward. When we do the Doppler, we're really concerned about the peak systolic velocity, and that should be less than 120 centimeters per second. We're going to change our probe position now from anterior to that coronal or axillary line probe position, just like we talked about earlier. The notch of the probe is going to be superior or towards the patient's head. And so this is a cool illustration. These lines are showing the sound as it goes through the body. So the probe on the side is going to come between the ribs and look at the kidney, and then look at the aorta on the other side. So I always refer to this as stacking the anatomy. So your probe is here. So it will look, you're coming through here and you're coming through the kidney, and then you're seeing the vessels just on the other side of that. So this is the image that this is projecting. So it is a great way to hopefully get the whole outline of the renal artery and vein. So you'll get color Doppler of the renal artery at prox, mid, or origin, prox, mid, and distal. Again, remembering that angle. And we are going to look for a few things. So by doing that peak systolic velocity, we want to make sure that the waveform is less than 120 centimeters per second. As we get older, it should actually go down. So the image on the top right is a normal waveform. You can see we have nice flow in diastole throughout the cardiac cycle. There's always red blood cells moving towards that kidney. If we look in the upper left of that image, you can see peak systolic velocity is 56.54. Perfect. We're happy with that. If you look at the image on the bottom, it's quite different. So while we still have a lot of flow in diastole, they're pointing out some findings here with the concentration of the blood flow. But look at this peak systolic velocity. We're at 659.32. Anything over 180 centimeters per second is very concerning for significant stenosis. We will take the renal artery Doppler information and we will compare that to the aorta. So what's coming out of the aorta? Is it making its way to the kidney, or is there a disruption along the way? So that comparative is called a renal to aortic ratio. So we take the renal artery peak systolic velocity and divide it by the aortic peak systolic velocity. And if that number is greater than 3.5, it's abnormal and indicative of a 60% or greater stenosis. Here's just a little tip on how to avoid or how to accurately get a 60-degree angle or less. So if we're straight anterior on, this is the aorta in cross section, and then the renal artery on the right at the origin. If our probe is coming straight down, it's going to be really hard to get 60-degree angle. So you'll angle your probe, kind of shifting it over to the right side to create that angle that will allow you to get 60 degrees or less. So that's really important. Otherwise, your peak systolic velocities will not be accurate. I don't want to forget about the vein, and I know we're kind of getting close to the end here. The vein is important. We must do color, grayscale, and a Doppler, and we're really looking for occlusion. Do we have complete flow through it? So this one's very quick assessment, but you don't want to forget about it as part of the Doppler study. So that was the direct technique. Looking at the renal artery proper and the aorta and doing those comparatives. The indirect is where I told you things kind of get a little not consistent across all labs. So we're looking at the intrarenal vessels, and we are again looking for low resistive flow. So this is a gorgeous picture, again, from the internet with the segmentals, the intralobar and the intralobular. The arcuates are going to cross horizontal over the base of the pyramids. So your assessment, your indirect assessment will be something intrarenal. So indirect intrarenal. All of this will be done by a coronal or flank approach along that mid-axillary line. You'll want to change a few things when you get over to the intrarenal portion. You'll want to be aware of how you can maybe make your sample volume bigger. Usually when you're in Doppler, there will be an option that'll say sample volume or SV, and you just make that bigger. The gate will open up, and then you can adjust your sweep speed to really get a good look at those waveform characteristics. When we get the Dopplers, we're looking at a few things. We're looking at how quick does the blood rise to peak systole? That's called acceleration time. We're looking at the shape of the waveform. So that's why adjusting your sweep speed allows us to see maybe blood that's trying to get up to peak systole, but takes longer because it's there's some impedance there. So that would be called tardus parvis, which stands for slow and weak. So we'll look at the waveform, look at the upstroke of systole, and measure peak systole and end diastole to get a resistive index. So there's a lot of things we're kind of looking at. I think most sonographers, once you get the hang of this, subjectively can kind of just look at that waveform and say, oh, we're going to need to really like assess this a little bit more. So acceleration time, that's slow, is not good. And a resistive index that's above 0.7 is not good. Remember, we just want all that blood to get to the kidney as quickly and as effectively as possible. Here's just a comparative of what we're measuring for resistive index. So that takes peak systole and end diastole, and also acceleration time. So we want to see, when did systole start and when did it end? If that's slow, that's a problem. We want a quick upstroke in systole. So what does it look like when it's not right? It looks like a high velocity, abnormal ratio. So turbulent flow that is aliasing. So when you put color on, you're getting that constant alias appearance. You have to bring your scale up to accommodate how fast the blood is moving through that stenotic area. And then when we compare systole to diastole, there's a bigger discrepancy because the blood is just trying to squeak through that stenotic area whenever it can. So we have a high resistive, high velocity flow. So while renal angiography or arteriography is the gold standard to really determine the problem, that's costly, it's invasive, and so we are a really good tool to kind of see if this ball is in motion. Is this starting to happen? Is a renal arteriography or angiography indicated? We're a good starting point for patients that have risk factors. And here are just some examples of, on the left side, things that are going well, and on the right side, things that are not going well. So we have here that dicrotic notch, which is good. Over here, this is not good. This is a tartus parvus waveform. So it's kind of slow and having a hard time getting up to peak systole. So the shape of that waveform looks abnormal, as does the one below it. This is what we want. We want that nice, sharp upstroke, quick to get to the kidney. Okay, that was my last slide. I know I threw a lot out there at everyone, so I'm happy to try to answer any questions that you might have.